Arguably, the most complex area of the body to inject into is the spine. And if you look at the anatomy, it will help you so much. And so you can see here where we've got a normal spine, you've got the vertebrae, the discs, the spinal cord. The spinal cord is very protected. That's why it's not easy to do an epidural, because you've got to have the spinous process position just right so it's open enough to do that intrathecal injection. But if the muscles and ligaments, if they're too contracted, it becomes very challenging. So we're not doing any intrathecal injections. You'll have to go elsewhere if you want to get training on that. Abnormal spine, you'll see where it's misaligned. You'll get a swollen disc. You can see where there's nerve interference that can happen, causing an inflamed facet joint. Muscles will tighten in response to that nerve interference. So what I'm going to do is try and break this down into very simple step-by-step process so that you can actually understand how to inject the spine well. And we did a training just last week, and so we'll be uploading that video very soon. It should be up on the site actually right now. It should be uploading anyways. I don't know if it's complete. It takes a little bit of time to get all these videos uploaded for you, but we're always updating, so make sure you check in frequently. All right, so let's jump into this. So the very first thing is, if you look at low back pain, we don't always know why low back pain shows up. A lot of times we think that we know the QL is in spasm, that's what causes it, or he had disc degeneration and that's what's causing his low back pain, but it's just not that cut and dried. But 80% of us will have some type of low back pain in our life. In the United States, this is the second or third leading cause of visits for the physician. Common cold, typically number one. It's also the most common cause of disability in patients who are over 45 years old, which I think is pretty tragic. But if you look at low back pain, there's different areas where it will show up. Typically, it's going to be below that 12th rib. You could have it posterior to the iliac spine. But you want to isolate the major conditions, the major parts of the spine where the low back pain is coming from. And then as you're isolating that, then you want to figure out, well, what's the cause of this pain in the first place? Because remember, there's the psychosomatic version of it. There is definite known cases where it's 100% psychosomatic as far as we can tell. But first of all, is it a mechanic issue? Is there osteoarthritis? Is there some type of herniation? Is there spinal stenosis, spondylolisthesis? Is there a compression fracture? Is it non-mechanical? Is there a tumor? I mean, and if it's non-mechanical, like a tumor or infections, that can be very dangerous, because you want to be able to isolate those things and make sure that you rule them out before you do any type of stem cell therapy for them. Do they have osteomyelitis? Do you have discitis with the infection? And sometimes just treating the infection actually gets rid of the pain. But you want to look if there's inflammatory arthritis, rheumatoid arthritis or ankylosing spondylolisthesis. Those can be very degenerative by nature, and it's going to take more than just an injection in the spine to really treat that. You've also got to treat the inflammatory components by testing the stool, looking at their hormones, finding out any food intolerances, anything that can be triggering that inflammatory response. And then you want to look, is there a visceral disease? I mean, do they have issues with their kidneys, their pancreas, their liver? Do they have PID? Do they have prostatitis? All those things need to be ruled out when it comes to diagnosing low back pain. Some of the red flags, of course, are going to be history of cancer. If there's metastatic cancer, that's where they get unexplained weight loss. They can be typically over 50. If there's an unexplained fever, recent bacterial infection, immunosuppression, check for infection. If they've had a fracture, you want to ask them first and foremost, have you been on steroids? Because if patients have been on long-term doses of prednisone, or in some cases even short-term, or if they've had multiple cortisone injections, then they're more likely to have a fracture, because every time you have a cortisone injection, you can have a bone loss of up to 8% in 4 months. And so if they had 3 that year, then especially if it's in their spine, then you say, man, your chance of having a fracture increased exponentially. It can cause osteoporosis. So you want to find out if they have osteoporosis, if there's recent trauma. Look at their age. If they're over 70, that could be a problem. The other red flag is cauda-equina syndrome. Are they having urinary retention or incontinence? Saddle anesthesia, decreased rectal tone. They have got, rectal incontinence can be one of those things. They can, literally shit the bed. So that's something you want to be looking at. They can have bilateral lower extremity and weakness and numbness. They can have severe progressive focal neurologic deficit. Maybe they have failure to improve, or they've had pain for more than 4 weeks. But most of the time when they come to us, they're going to already have ruled out these things, and stem cell therapy is kind of their last resort because they've tried the steroids, they've tried medication. A lot of these patients will have had surgery, but you want to make sure that you're looking at all the red flags. And then if we jump into any radiculopathy from the lumbar spine, any pain radiating down the legs is typically from L4, L5, or L5S1. That's 90% of the radicular pain. With inflammation, you're going to have mechanical compression, so some decompression therapy. Many of you have the decompression tables, which will be pretty awesome. If they have pain sitting or bending or with coughing, or if they have pain that radiates below the knee or in a narrow band, this is radiculopathy. And so you want to look at that and kind of see, well, where is it coming from? If it's coming on the medial side of the leg, and if it's affecting their dorsiflexion, their sensory nerve that's going to be affected is their medial ankle, but the nerve root's going to be L4. If you look at L5, it's the lateral leg, the dorsum, the foot. They're going to feel some numbness there, or some burning pain or nerve-like pain. It's going to affect the big toes dorsiflexion. That can show up in the sensory nerve of the space between the first and second toe. For you acupuncturists, right around the liver 3 area. S1 is going to show up on the posterior calf or the lateral or sole of the foot. And this can affect the foot plantar flexion. It can also affect the lateral aspect or the sole of the foot. So you want to be using your pinwheel to determine where this issue is actually originating from. If you look at it congenital, it can be an onset in the 30s. If you were wondering, a spinal stenosis, where does that show up? Most commonly, this is a degenerative condition. Its onset is late 50s, early 60s, and it usually involves L4, L5, followed by L3, L4. Now, with lumbar stenosis, what you'll find is that these patients have like a variety of different symptoms that can show up with it. And don't be too intimidated by spinal stenosis. We've seen severe, moderate, and severe spinal stenosis where I told the patient I don't know that this is going to help because of the amount of debris essentially and calcium and collagen that's built up around that foramen, but they still do incredibly well when you inject the stem cells and infuse it around that spinal stenosis. Then what you'll see is the cytokines, the growth factor, even the hyaluronic acid will start pulling off some of that material so that the joints will loosen up and they'll have better nerve flow in through that foramen. You'll also see that when the tissues heal around that foramen, there's less degeneration that occurs. If they've got mechanical compression, then that's going to affect the vasculature, so they're not going to have as good blood circulation into the area. Or they can have nerve root ischemia, where they've got no blood that's gone to the nerve root, and so that nerve is essentially dead. And we've actually injected, we've had several cases of ankylosing spondylitis, and we inject it, and suddenly, because we provide some life and vasculature to that nerve root, then the patient actually has gotten sciatica. And suddenly the nerve pain came back because it was just numb before then. So warn your patients before you do this procedure. You can have increased microvascular permeability and edema, so they can have swelling in the area with stenosis. This is what stenosis looks like. You can see the spinal canal in a normal patient. There's going to be a nice amount of space for the spinal cord to go through, but you can see with stenosis, that's where you start to get this this buildup and scar tissue and that calcium and collagen formation around that that nerve. And so, one of the things we want to do is you're going to be injecting right through this area, right around the facet joint, fanning this entire area. And then the stem cells will be able to mobilize themselves into this inflammatory area that's releasing lots of cytokines, communicating with your body. There's a big problem because that's a big nerve, and so the stem cells will be drawn into that area just like a magnet. So once again, you don't have to do some type of intrathecal injection to help with stenosis. If it's foramen stenosis, then same, you're just going to be injecting around the area. If you look at the stenosis, how it can be an insidious onset. It can be chronic back pain that progresses to the buttocks, thighs, and legs. It can show up with fatigue, with heaviness or pain in the legs, with neurogenic claudication, so they can suddenly have no function. Their fate will go out from under them. Most common is a loss of lumbar lordosis with limited extension. They'll have the flat back and no ghetto booty on this person. The trunk is flexed forward with standing and walking. They can show up with the simian posture, for those of you who have seen that. Most of us on our cell phones are eventually going to end up with this. And there's going to be more stenosis because our heads are pushed far forward, just like we trained you on in the postural assessment. There's going to be no significant tenderness to palpation, typically, especially with spinal stenosis. They'll have a negative SLR. They're going to have a normal motor exam despite reports of weakness. Their symptoms, if you want to rule it out, you want to look at, is this a neurological issue or is it vascular? And the neurologic, what's going to happen is the neurogenic, the back pain will be common. If it's vascular, it's going to be uncommon. So symptoms are going to show up in very different ways. With pain relief, with neurogenic, they're going to have pain relief if they're in a sitting or flex posture, or even if they're standing and resting. That's usually insufficient. So often it will be slow. The pain relief within may take more than 5 minutes. If they go back to sitting, then the pain will slowly resolve itself. With vascular, it's not positional. It can be any type of position. So, they can be sitting on a bike. They can be riding their bicycle, and if it's vascular, it's going to be painful. They quit riding, they start walking, thinking that will help, and they still have the pain. That's going to be more of a vascular problem. But pain relief while standing, and then it will come almost immediately. The ambulatory tolerance with neurogenic, it can be a variable depending on the movements. With vascular, it's going to be more fixed. Uphill versus downhill. Downhill is going to be more painful. The extended posture is going to put more pressure on the nerves, whereas uphill will be more painful because they are, they're in more of a sitting position, and the hips are extended more, so you're going to see that there's going to be more pain that way. The bicycle ride, like I said, there's going to be no pain if it's neurogenic. That's where that sitting posture, it relieves the pain. If it's vascular, there will be pain. And so what does this mean? Well, it means on the vascular side of things, there are proteins in the amniotic fluid, the umbilical cord tissue, that actually promote what's called angiogenesis, so you can get better vasculation, better vasculature grown in that area. But you just want to be able to isolate where is it coming from. And if it's vascular, then that's where you really want to start palpating and get very specific as far as what vasculature you determine is affected. If it's neurogenic, then it's fairly simple to determine, well, is it L4, L5? Is it L5, S1? Where do we need to inject based on that nerve root? Where does that nerve come from? And so that's how you'd use that little graph. The anatomical source of low back pain is very controversial. It could be from discs, it could be from the facet joint, could be from the SI joints, could be ligaments, muscles. We just don't always know, and so that's where developing X-ray vision on the tips of your fingers is going to save your life and your patient's life. You'll be able to diagnose and treat so much more effectively that way. SI joint, we find the majority of patients have some type of SI joint instability. and facet joint. I mean, there's multiple. So here's a sagittal cut where you can see the posterior muscles and ligaments of the back. You can see right where the facet joint is. That's where we're aiming. The majority of the stem cell injections are going to be right into the facet joint, right around there, because that facet joint leads to the canal that goes into the nerve roots and can heal everything. You can see where the disc is, all of those things, from an anatomical perspective. So low back pain is not a black and white musculoskeletal condition. Here's some of the studies with an MRI. It often shows abnormal findings in patients who are asymptomatic. At age 42, you'll see 52% of disc bulges and protrusion in 27% of asymptomatic adults. That means more than half of the people walking through your clinic, they may have a clean MRI, but they may have no symptoms, but they can still have issues in their MRI. After the age of 60, these findings are even more common. Spinal stenosis will show up in 25% of asymptomatic adults over 60, which I think is crazy. I mean, you think about all the patients who come in, and we take them through this whole process of getting their MRIs read, but really at the end of the day, we really want to just go off of our own physical assessment, because the MRI, even though it shows the patient may be asymptomatic, they can still have massive things going on, or they can have massive things that are going on in their body, and they have nothing that shows up on an MRI. And I can't tell you how many times that's happened. And then what happens at the next step is, once the test is ordered, for those of you who are medical doctors or nurse practitioners, physician assistants, you'll see that next step is, okay, let's do an epidural, a steroidal injection, or let's do some type of facet intervention, or let's do some sacroiliac joint intervention, or maybe you'll do the sympathetic nerve block, discography, or even the radiofrequency treatment, or the spinal cord stimulation. Have a neuromodulation, or then do the intrathecal pain pump, where you just got this massive dose of morphine going into your body all the time. It's super healthy for you, and patients love it. No, they don't. They actually get really sick and toxic on that. Here's some risks of the steroidal treatments for those of you who are doing it. You remember in 2012, the New England Compounding Center in Framingham, Massachusetts, the CDC finally shut them down after an investigation in September of 2012, because they found contaminated steroids. This is the prednisone that had fungal meningitis and it causes spinal abscesses. So it had mycotoxins in it, and there were 751 cases across all 20 states that ended up in 64 deaths from this fungal meningitis, from the mycotoxins that were found in the contaminated steroids. So not always safe. So do not use those types of steroids. Here's what we find on the vasculature. Like I said, there's neurogenic and there's vascular issues when it comes to spinal cords. So you want to make sure that you're not only infusing the stem cells and infusing it around the area to help the nerves, but you're also helping the vasculature. Because if you don't have good blood flow along the spine, then it's going to be really difficult to help a patient improve. Here's what an epidural, the anesthesia epidurals. This is the intrathecal procedure. This is where we're going. We're aiming more for the facet joints when we're doing your treatments. The facet joint, watch the live video trainings. You'll see me drawing a line. You always want to go on the intervertebral, so you find the spinous process, and then you go right in between the spinous process and just go lateral, about an inch lateral. And if you go straight into that, you'll hit that facet joint. You'll be right on top of it, and then you can infuse the stem cells right around there. Here's an image of a needle with the facet joint. You can see here's the spinous process, here's the spinous process. Just almost right between them, that's where the facet joint starts. Once again, spinous process, go lateral about an inch, and you're right on the money, right in that lumbar facet joint. So, first thing is grab your patient, find and mark the spinous process. You can actually draw a little circle around it. You'll draw a circle there, find the center spot, and then just go lateral to that. You'll be right in that facet joint. Easiest way to find it. Here's another image of it. Once you're in the facet joint, you'll get all that cartilage, the articulation. You'll also get these nerve branches. Once again, another cool image, because once again you're going spinous process. Here they are sticking out there. Needles coming right through, straight into that formation there, right into the facet joint. A lot of the research has been done around the sciatic nerve regeneration. What are the causes of sciatica? Well, it could be a bulging disc, it could be an inflamed joint, it could be the muscle spasm, your piriformis and obturators. And so what the researchers did is they took 1,700 rats, and they actually severed the nerve, the sciatic nerve on these rats, and they wanted to see first of all two things. Would the human amnion tissue injected into the rats, would it help repair the damaged sciatic nerve? And they also wanted to know, the second thing is, will it cause a host response in animal experience? And what they found is that in virtually every case of the rats, that sciatic nerve regrew, and then there was zero adverse reaction. So none of the rats' immune systems rejected the tissue because there was no antigens in it that caused any issues. So sciatica is a powerful treatment for it. We're actually treating a patient who's got pudendal neuralgia, which will be really interesting. And he's got a whole community of people with pudendal neuralgia. The way of determining where the pain is and what part of the nerve is, rectal exam. So it's not a super fun procedure, but for those of you, if you have a patient with pudendal neuralgia, then let me know. We can give you some guidance on that. Disc herniation. So you can see what a disc herniation looks like. You can see that herniated disc compressing on the nerve. And, a disc is kind of like a jelly-filled donut. As the day goes on, we get shorter and shorter. That synovial fluid starts to leak through, and then it starts to create inflammation. And then because it's putting pressure on those median nerve roots, and then you can start to get a significant amount of pain. Once again, some people can have this disc herniation and no pain with it. But what we want to do with the stem cells is you don't have to inject right into the disc, but that hyaluronic acid that's naturally occurring, and once again, the hyaluronic acid found in the amniotic fluid or the umbilical cord tissue is about 400 times more potent than the synthetically derived amniotic fluid or hyaluronic acid, excuse me. But even the high chain hyaluronic acid that's found in the Wharton's jelly, that's about 30 times more potent than the hyaluronic acid itself. So it's very powerful. So what we're going to do is inject right around that disc space. Once again, you locate the facet joint. You go intervertebral spaces where you're always injecting, and then you're going to go right on top of that facet joint, and that will create a nice channel for the stem cells to migrate into that disc space. And we've seen discs retract within 4 weeks, and you'll see it in some of the research here. Here's where you see a normal disc. If you look at the examples of disc problems, degenerative disc, you can see it starts to shorten and weaken, and then you get osteophytes that get built up around that degenerative disc. Bulging disc, that's where it starts to protrude, push on the nerve. Herniated disc is where the disc, actually the fluid starts to leak out and push against that nerve. And so that's where the stem cells, you want to make sure that you're on that right level. So know your anatomy well. You're on the right level so that the stem cells can actually repair that tear in that herniated disc. A thinning disc, that's degenerative disc that's gone long term, and that disc is not replenishing itself. So this is where, having a patient hang every day, anyone who has degenerative discs, have them, they want to do some gentle but weight-bearing exercises. And then the other thing they can do is, if you're doing decompression, that's a great therapy for it. Acupuncture is also a way of promoting better blood circulation into the area. So if you're injecting it, once again, disc herniation injection, you're going to go right into vertebral space. You're aiming right into the area where the disc is herniated. So once again, you're going to go just about an inch lateral from the spinous process and the intervertebral space, and you'll needle, your needle will go in depending on the size of the person's paraspinal muscles. You'll go in maybe an inch to an inch and a half, but right when you get that gummy sensation, that's when you've hit the right spot. And then you just want to pull the needle back a little bit and just infuse that entire area. I'll infuse about half of a cc per site that's got the herniation. So if it's on, I'll do a half of a cc on one side and then half a cc on the other side. So you typically are using 1 unit per area that's been compromised. If someone's got multiple levels, then we may start with 2 or 3 units and just see what type of progress they make. Once again, there's where the facet joint is. The nerves are right around there. So you're going to be going intravertebral space. You're going to inject your needle. Your needle's going to penetrate and go in for about an inch to an inch and a half. You'll feel some gumminess. Do not do this fast. Go nice and slow and easy. If a patient's super sensitive, then you can always use some preservative-free lidocaine. Make sure it's preservative-free, otherwise the stem cells will be affected by it. But do some preservative-free lidocaine, numb the area, and then push the needle in inch to an inch and a half. For SI joint pain, sacroiliac, this is very common. The very first thing you want to do is have them march in place, and if their SI joint is not moving properly, that's a very, very big indicator they've got some arthritis there. So see if they've got any type of inflammatory arthritis first, but then look for an abnormal gait pattern. These people, one leg will have a much wider gait than the other. They can have some leg length discrepancies, and you'll think, oh, you got one leg that's longer, let's put a shoe lift in. That's only true in a very small percentage of the cases. But what you'll find typically is it's an SI joint dysfunction where the SI joint is actually trying to fuse onto the sacrum. So the iliac crest is fusing to the sacrum. Not good. And the way you find the SI joint is just with the PSIS. And one of the easiest ways when you're marking your landmark is go in there in the room. And after I did the training, it was so cool because Monday I came back to the office and our nurse practitioners are doing a spinal injection. And I see them marking all the anatomical landmarks so they know exactly where to go. And that's how we train on the course, the injections course. But that's all you have to do is just trace a line on the top of the iliac crest. And then as that crest comes around, you'll see these bony landmarks, and those are called your PSIS, your posterior superior iliac spine. And then you just mark where that PSIS is, and then you're right there. Right along that medial border of the PSIS is your sacroiliac joint. And so you can see that where there's a lumbar fusion, trauma can cause it, scoliosis, pregnancy, all those things can create SI pain. Some of the clinical symptoms is you'll have pain near the PSIS in the gluteal area. It will typically be unilateral, but not always. Pain when rising from sitting. That person will be like, ugh, and they'll kind of stop midway, and then they'll pull themselves up. It may be somatic or referred pain down the leg. Typically, it doesn't pass above L4, L5. That's the level of the iliac crest, and that's going to be kind of right at that, above the PSIS. Exam, there's multiple ways. The easiest way is the Fortin finger test. And with the Fortin finger test, all you have to do is have the patient use one finger to localize where their pain is. And then, what will happen is a positive test is when a patient twice identifies the painful region within 1 centimeter of the inferior medial, of the area inferior medial to the PSIS. So have them put their finger on there. If they're right into that, right around the PSIS, maybe just a little inferior to it and medial to it, then you'll know, okay, this is what they've got. And it's a very easy test to do. What you'll find is due to the attachment of the long and short posterior SI ligaments to the PSIS, pain is often localized in this region because of the SI dysfunction. Here's what an injection site looks like. So there's the PSIS right there. You're finding a nice opening. So the thing is, if you come too far inferior to the joint, you're ending up on the sacrum, and your needle is only going to go in like a half an inch, and then you're going to hit bone. So what I recommend is you go superior. You just go almost lateral to the very top. I would even position the needle just slightly superior to where it's at now. And you'll find yourself right in the PSIS joint. You're going to push the needle in about an inch and a half. You'll feel some gumminess. You infuse a half a unit there, pull it out, and then fan it with the needle facing almost at a 60-degree angle, and the needle is actually directed inferiorly, so it gets the rest of that joint, and you just fan it through that entire joint capsule. You put 1 ml is needed for an SI joint. Unless the SI joint's not too bad, you can start with a half, but typically it's going to be 1 ml. Here's some studies with bulging discs. You can see where the discs are injected. 5 weeks later, they do another scan, and you can see from this image that the disc actually retreated. There's no more bulging disc in that patient. Lots of risk with surgery. We're trying to help people avoid that because spinal surgery is very risky. An interesting study, the New Yorker online magazine, they published this, found that patients who had received spinal surgery, 72% needed further surgery. So a lot can happen with your patients who have degenerative discs. Even if they've had spinal fusion, this will help in bone growth. We've done with patients who have had spinal fusion, we will inject the segments above where they've had it fused. So let's say they have L4, L5 that's fused. We'll do the L3, L4 segments. We'll do a half a unit on bilateral, and it helps from the degeneration, and it helps the pain substantially. Here's another study where the researchers went in, they injected the L5-S1 disc protrusion, they injected the air around it. You can see just 4 weeks after the injection, that disc protrusion was, it retracted. So lots and lots that you can do when it comes to the spine. For SI joint issues, for disc issues, for stenosis, all those things can be treated very effectively. And, once again, it just takes a lot of confidence. But if you find the intravertebral space, you go lateral to that about a half an inch, and then you put your needle into that space. You mark the spot, clean it, put the needle into that space, inject about a half of a unit per segment. You'll see phenomenal results. So come to our next hands-on training, watch the live videos, and if you're still not confident, then you're going to have to get here in person. But hope this has been helpful. Get going on those cases. Make sure you're filling out your good bio outcome if you're using Vera Bioscience. We're trying to track all these so we can have proper clinical data and then release a clinical outcome study. So can't wait to hear about all your wins, and enjoy your next training video.